All right.
So, yeah, welcome everybody. And here's Kurt talking this week about basket trials.
All right. So I am Kurt Veely. I'm the Director of Research at Berry Consultants. Thank you all for joining or watching later, as the case may be. You can see information on contacting me on Twitter or LinkedIn. We do answer questions and provide content every week or so, every couple weeks, depending on the schedule. So blogs, videos, etc., like this. Today we're going to talk about basket trials. And one thing that was interesting as I was preparing this, I realized that basket trials are a very different kind of setting than what we've talked about in the previous examples. So we've talked about escalation, we've talked about seamless trials, RAR, group sequential. In a lot of those cases, you can point to generalized improvement by being adaptive in some way. So if I'm in a multi-arm trial, putting in interims and eliminating arms that are performing badly, whether you're doing arm dropping or RAR or whatever, that's advantageous to you. It's an efficient way to use resources as compared to just running a fixed trial and saying I'm just going to allocate X patients per group and not look at the data until the end. There are clear things that you are gaining in terms of increased power and increased number of patients being treated well, and so on. Basket trials are a bit of a different beast in terms of there's a lot of trade-offs in using a basket, and so you really have to think hard about what are you valuing in a particular setting to decide if a basket trial is for you. There are cases where a basket trial is decidedly not for you, and there are cases where certain kinds of baskets may work better. So I want to get into that, but keep in mind that this is going to be a lot of discussion of trade-offs more than here is the key pro or the key con, as the case may be. So our usual outline, talk about the basics of basket trials. What problem are we solving? How do basket trials work? And what advantages might occur in practice? And again, some discussions about disadvantages as well. We'll talk about a FACS implementation, talk about the key things you would want to change in FACS. So again, we'll give a template, which will be available after the webinar. And I'll talk through how to change the decision rules and the final analysis. So I spent a lot of time in preparing this talk, changing a few settings in order to try to optimize the trials. So I'll talk about what those settings are. Some advanced topics that we'll cover. Type 1 error control is a big topic for basket trials. What do you consider type 1 error control? Under what settings? What do you need to prevent, essentially? And we'll talk about borrowing information a bit in this particular setting. We have other videos on hierarchical models, so I will assume that there's some familiarity there and just focus on the design. And then finally, we'll close with some regulatory discussion. And really, basket trials remain, there's an uncertain landscape in phase 3 for basket trials, really depending on which division you're working with at a regulatory agency. Okay, so what problem are we solving? A lot of trials, they start off, they enroll a pre-specified population. And people have recognized that there's maybe patient heterogeneity. We may have a drug that works for some people and not others. And so the question is, well, can we figure out who does our drug or generally our therapy work in? Additionally, we see a lot of targeted therapies these days that are aimed at what might have been considered multiple indications in the past. So in oncology these days, there is a lot of drugs that attack a certain kind of mutation on the tumor. And so we don't talk so much about, this is a treatment for breast cancer, or this is a treatment for prostate cancer or thyroid cancer. We talk more about this is a treatment for a tumor that expresses a particular mutation. And so it might work in those multiple indications. This has come up in epilepsy. There are multiple different types of epilepsy syndromes, depending on just the where in the brain and what the electrical issues are that are happening behind the epilepsy. So a treatment might work in Lennox-Gastaut, it might work in Dravet, but people want to consider applying a therapy to potentially what might have been viewed as multiple epilepsy syndromes. We also see this in stroke. We know that there's probably a window of time where a therapy might be effective, and a particular severity of stroke where a therapy might be effective. If the stroke is mild, maybe everybody recovers. There's no need to, do some invasive therapy. If the stroke is incredibly severe, tragically, there may be nothing that you can do. So stroke trials, often a lot of their effort is spent on trying to say, what is the window? What is the stroke severity? Who exactly should we be treating? And who can we help? So in all of these kind of settings, we're still interested. There's multiple patient populations or subpopulations, and we're trying to figure out what is the ideal subpopulation. A couple different regulatory pathways where we might want to do this. Sometimes we may be in a phase 2 kind of setting. That's the example that I'm going to cover. And what we'd like to do is maybe enroll broadly in phase 2 and try to figure out what groups look promising. And then we would take those to a phase 3 trial, which might be a more standard kind of trial, a basic kind of 1-to-1 randomized, whatever is standard for that area. But so we may be in phase 2 trying to identify the phase 3 population, or we may be in more of a phase 3 setting where we actually are doing this trial to gain approval for subgroups. So at the end of this trial, I want to actually say the subgroups where I win, I want approval in those subgroups. That's a different kind of setting than identifying a population for a future trial. Okay, so the reason that basket trials are important is that not doing a basket trial presents difficulties. So the alternatives are bad, is what the issue is. If we have these subpopulations and we have to make some choices on what populations we're enrolling, if we just specify a broad population and just pool everybody together, which is what a standard trial would do, 1-to-1 randomized trial, we write out, here is the inclusion, exclusion, we'll analyze everybody together, and our result in effect is works for everybody, or, fail to reject the null hypothesis. So if we're in that situation where we're doing this kind of pooled analysis, if we enroll broadly, so we enroll lots and lots and lots of subgroups, then what we may be doing is we may be enrolling patients where they don't benefit. And so we're going to dilute the treatment effect. So potentially our trial may have reduced power, or simply take more resources than is needed to detect a treatment effect. So enrolling patients that don't benefit. is problematic. And probably more importantly, just the ethical imperative of we don't want to be, at the end of this process, we don't want to approve a drug for people where it doesn't work. Now, in practice, of course, we probably always do that. So every drug on the market, probably there's an exception where these patients are in the label, but they don't benefit. The mere fact that we have second and third line and fourth line therapies for anything says that that is true. So broadly, we worry we're diluting the treatment effect. We're potentially approving a drug for patients that don't benefit from the drug. If we enroll narrowly, maybe we're like, well, we're pretty confident we work here at least. So let's focus in. Of course, then we may miss people who benefit from the therapy. And so that's, of course, bad for the people who miss out on the opportunity to get the drug if it indeed works for them. And of course, if you come from, if you're a sponsor, you of course would like to have a market that's as broad as possible. So enrolling narrowly also has disadvantages. Also, if you enroll narrowly, you may find it takes longer to enroll your trial. Because you only are enrolling a certain kind of patient, it may be harder to find that kind of patient. Okay, so is anything better than doing this? And so what basket trials try to do is directly assess the subgroups. So try to identify here is where the drug is effective, the therapy is effective, and eliminating subgroups where the therapy is ineffective. Just as kind of a nomenclature, this discussion of subgroups where the therapy is effective is a little clunky. So I'm often going to say an effective subgroup or an ineffective subgroup. And that's a little bit inaccurate, but it avoids extra words for this discussion. Keep in mind when you're in this setting that you're likely never going to be sufficiently powered for all the subgroups. It is often really hard to do this. So this is often just a challenge that's sitting in the background. So we're not going to be talking about, things are difficult for small groups. Okay, so how does a basket trial proceed here? So usually we will start by enrolling a population, and usually we start with a broad population. So usually we start with we say, this is the outer boundary of who I think I might help. And the goal of the trial is to try to narrow that as we continue. You can do it in the reverse order where you start narrowly and expand. That is usually a concern when there's a safety issue, for example, but often inferentially, if you're just interested in efficacy, for example, starting broad and narrowing is the way that we often go here. So then what we would do is, our usual every adaptive trial, essentially this phrase is in every slide deck we've presented. We perform periodic interim analyses. So every once in a while, we look at the data. And so we will analyze each of the pre-specified subgroups in our trial. So does it work in group A? Does it work in group B? Does it work in group C? And we will drop any subgroups that are performing poorly. So this subgroup doesn't appear to benefit. We're going to stop enrolling this and move on with what's left. You may also stop subgroups that are performing well. So you don't have to, but if you want to go ahead and say, I think I'm going to, this group's doing great, I'm going to stop it, that's fine as well. So we've been involved in the design of a trial called ROAR, which involved multiple rare cancers. And ROAR had the very nice result that some of the subgroups had, this was a phase 2 trial, but it had some incredibly good performing subgroups in it. And so what happened is those subgroups were stopped, and then the trial went to the FDA with information from other trials that were investigating the same therapy, and they got subgroup specific approval in the things that graduated. As it turned out, ROAR eventually was part of the package that for this drug, there was eventually broad approval on the target for the therapy. So it ended up, this was a success across the board in these subgroups. But that wasn't known that that was what was going to happen at the beginning. But you certainly can graduate and say things are going well if you would like. In the final analysis, so we've got this adaptive procedure. We start broadly. We've got a number of pre-specified subgroups. For each of the interims, we're typically narrowing the population down. And so by the end of the trial, we've got a subset of what we started with. And so now the question is, how do you analyze that final group? And so there are a couple options here. If you're in the frequentist paradigm, a lot of times they will perform a pooled analysis on whatever is still enrolling. So you ignore all the data that in the subgroups you've eliminated, and you would pool what's left in the hope, of course, that what's left is your effective groups. Obviously, you can't guarantee you will do that perfectly, but the enrichment, the whole purpose of the name of an enrichment trial is what I'm left with at the end has a higher fraction of effective groups than I started with. So that's what I've done to enrich. And so by pooling what's left over, I'm hoping that I'm now pooling across effective subgroups. And of course, you do have to, if you're doing this kind of analysis, you have to worry about type 1 error control in terms of you've picked subgroups out. So there may have to be a penalty. In phase 2, obviously, type 1 error control is largely a sponsor decision, and so you don't have all this 2.5%. But if you were doing this in a regulatory setting, you would have to be very careful about how you eliminated groups out. I'm going to focus mostly on the phase 2 kind of setting here. So that's the frequentist, enrich and then pool what's left over. In the Bayesian setting, we often use some kind of hierarchical model, and we would borrow information across groups. So essentially a hierarchical model says that the groups are exchangeable. That's a modeling assumption like linearity. It doesn't have to hold exactly for the model to still be valuable. So we assume exchangeability, and so that would allow us to, it doesn't pool, but it allows the groups to combine information. It's also possible for you to do separate analyses at the end of the trial in each of the groups, but keep in mind that really will just reduce you to separate trials in each subgroup. So you lose some of the benefit of the basket if you never combine the information, because you never get to see the whole as more than the sum of its parts. We'll talk a little bit about this in the future slides. Tom, is there a question?
Oh, well spotted. Yes. Can we use adjusted analysis, adjusting for each subgroup in the analysis model? This gives us a weighted average treatment effect.
So you certainly could get a weighted average treatment effect. It really depends on your purpose. In a lot of settings, people are doing this kind of trial because they don't consider that the kind of average treatment effect is they think the population is a mixture of where things work and where things don't. So the average is an average of potentially an average of unlike things. So you often don't see that. Now, as I said, there are examples where you may eventually decide, maybe I just want to approve for everything because I'm seeing that every subpopulation is working. And so that may be something that you'd want to do. So in theory, there's nothing, there's nothing that says you can't do it, but it is typically not done in this. You really want to get a subgroup specific estimate. Certainly something like the hierarchical model will allow the subgroups to mostly stand on their own while bringing information in from the other ones.
Thank you, Kurt.
So one thing to keep in mind while you're doing basket trials, if you're designing these, the operational issues involved are more important than what we've talked about previously. And you have to constantly keep in mind what the effect of your decision rules are on your accrual stream. The reason is that what we talked about previously, like a couple weeks ago, we talked about multi-arm trials where we're investigating multiple therapies for a specific indication. Here we're going to have multiple indications, but a single therapy. So kind of the flip side. And there's a big difference here. If you're in a multiple arm trial and you stop an arm mid-trial, you don't change the accrual rate coming into the trial. You still have a patient stream and you're assigning them arms. If you drop an arm, you can just assign more of the remaining arms. If you're talking about subpopulations, when you stop those, I can't assign what kind of epilepsy syndrome a patient has. So if I say I'm running a basket trial and I'm going to stop enrolling Lennox-Gastaut, then my accrual will actually drop into the trial. So I don't have Lennox-Gastaut patients anymore. So if I'm trying to enroll, say, X number of patients, my accrual is now lower. And so that's going to affect either your trial duration or potentially the feasibility of your trial. So I've had discussions, a couple recently where we're talking about academic sponsors with grants. And so the worry is, they've got a couple different subpopulations, and what they'd like to do is potentially eliminate one of the subpopulations. But the problem is, if they eliminate the subpopulation, that eliminates half their accrual. And so it will make the trial run longer if they want to make it up in the other subpopulation. The alternative, of course, is just to have a lower sample size, which may be fine. So saving sample size, there's nothing wrong with that. But the advantages that we got for multiple arm trials, where by eliminating some arms, we can increase others, that is not, that has some operational cost in a basket. So you always want to be thinking about what can I do? The other grant that I've been working on recently, they're in a phase 2 setting, and they want to select a population for phase 3. And one of the things that you have to think about is, okay, what happens if I start with, say, 10 baskets, and I only find that 2 or 3 of them are effective? So I'm going to move on to phase 3 in those 2 or 3 baskets, but now I may be talking about a phase 3 trial that is very hard to enroll if those 2 or 3 baskets are hard to find. Whereas if I were going to move forward 7 baskets, it might be a much easier trial to enroll. this problem becomes all the harder if some of the baskets are bigger than others. So when we run, say, oncology trials, we may have colorectal cancer and other kinds of cancers, and colorectal is tragically relatively common among oncology indications, whereas other types of rare cancers may be harder to enroll. So all of these things you want to have in the back of your mind is, what are these decisions going to do to the duration of my trial and the feasibility of my trial? So I'm not going to dive into that in detail because of time, but when we're simulating trials, this is part of the equation. What's the duration? How long does it take? Can you do this? All of that is important in this setting. All right, so dive into example here. This is a phase 2 setting. I'm going to talk about I have 10 rare subgroups. So I'm going to run a trial, phase 2 trial, try to identify what rare subgroups. They're rare enough I can at least do development, but I'm going to try to identify which 10 to carry on to phase 3. So my kind of development paradigm here is run phase 2 in all 10, select some subgroups, and then I'm going to run a pooled phase 3 trial in all those subgroups and try to get approval in whatever I get into phase 3. I'm going to just run a single arm trial in each of the groups here. I'm doing this because it's a common setting. Nothing stops you from having a control arm, and I always like having control arms. It's just not always done for rare oncology settings for practical reasons. But certainly there's nothing, the world would not qualitatively change if you had a control arm here. What I would like to show in each of the subgroups is that I'm superior to 10%. So one way of doing this, for example, is if I just were going to run separate trials in each of the rare subgroups, I could probably get away with doing 15 patients per group. If I analyze those separately, I can achieve 5.6% type 1 error. That's one-sided, and 82.7% power. And I do that by declaring a group effective if 4 out of 15 or more responses. Power here refers to if I can, I'm hoping for 35% effects in here. So I'm hoping to get this 10 to 35. So, this isn't a bad screening mechanism. It does take 15 patients per group. That may or may not be easy enough to enroll. So there may certainly be problems with this. Okay, so one thing that we now want to talk about is what makes a trial have good performance, and so I'm about to ask, can I do better than separate trials? And so keep in mind, kind of in the back of your head, I'm going to talk about this, but good performance, there is going to be a trade-off here. And so we're going to spend a lot of time talking about what this trade-off is. Okay, so I'm going to consider 5 different scenarios in this trial. So what happens, the top row here is the joint null, where every one of the groups has a 10% rate. The drug does nothing for anybody. I'm also going to consider a scenario where 2 of the groups have the 35% of effect here. So the first 2 are at 35, everything else is at 10. And the remaining scenarios, I just increase the proportion of groups where the drug is working. So half of them are at 35, 8 of them are at 35, or all of them are at 35. And so what I want to consider here is, for the different kinds of methods that I'm going to bring to bear, what I would like to know is, well, how well does the trial work in each of these settings? And to really try to hammer at this trade-off idea, what we're going to find is certain designs work well in certain settings and work poorly in others. And what you have to do is kind of balance that. So we often ask clients things like, well, of these possibilities, which are things that you think are likely to happen, where you really desire good performance, and what are things that are possible, you'd like the trial not to, fall down, but they're less important to you. Because each of the designs that we're going to consider, there's going to be situations where, hey, this design works really well for this scenario, but maybe not as well for others. And the decision as one of my jobs is to try to make sure that all those trade-offs are enumerated and understood, and that the sponsor can make an informed choice. So there we've got our 5 decisions here. Question?
I'm not sure. I've asked. So someone's raised a hand, and I've
all right. I'll just
send them a chat to see what their question is.
Yep, interrupt anytime. So okay, so we'll start with just considering separate and pooled analyses. So in the top, what I have is what happens for the separate analyses. So I'm going to enroll 15 patients per group. Each of the groups is handled completely separately from all the others. And I'm going to say that I need 4 out of 15 to claim efficacy. So this has a typo in here that should be about 5.5% type 1 error, and about 82%, 82.7% power in each of the groups. So, and those decisions are all being made independently. So what's going to happen at the end of this trial is I'm going to do my 10 different analyses, and I'm going to decide what goes into the phase 3 trial. If I'm in the joint null, what's going to happen is on average, I'm going to take about half a basket, half a group into phase 3. So out of my 10 null groups, I take about half of them. And so another way to think about this is, remember, these are all separate analyses. So every one of them has this 5.5% chance of being successful. The odds that at least one of them is successful is over 40%. So it's not 55, of course, because they're not all disjoint, but it's over 40%. So one problem here is in this all 10, because of the multiplicities, I have a high probability that I'm going to need phase 3, and it likely will be a phase 3 trial in a small number of subgroups, which may not be setting me up for success. So the null's potentially problematic for separate analyses. There are some, as I get to these 235 and half 35 scenarios, there is actually an element, the separate analyses do a pretty good job of screening things out. So if I think of, let me just focus on the half 35. So that's 5 groups where it's effective, 5 groups where it's ineffective. If I look at the 5 groups where the drug is ineffective, this procedure, separate analyses, graduates an average of 0.278 out of the 5. So often this mechanism does screen out all of the ineffective groups. And then of course there's some chance that we'll get, maybe one of the ineffective groups will get passed through to phase 3. Remember, the ideal here is I get every group right. In practice, it is virtually impossible to say I'm going to get every group right with high accuracy. You have to accept This is just a hard problem to solve with a manageable sample size. In the alternative, this trial is actually pretty good about passing most of the effective groups. So I get about 4 of the effective groups into my phase 3 trial. So if I think of kind of the average phase 3 trial that I'm running, I've got 4.1 effective groups. I've got 0.278 ineffective groups. Obviously, that is an average. I have to have an integer number of each kind of group. But basically, I've done pretty well about getting most of the effective groups into phase 3 and screening most of the ineffective groups out of phase 3. So if I think about what that phase 3 trial looks like, I've got 4.4 baskets that I tend to carry forward, just adding these two. And then of those 4.4, I average really about 93.7% of them are effective groups. Obviously, this is an average over a lot of different possibilities. Getting everything exactly right, or missing one in various directions, smaller chance of missing 2 in various directions. But I'm talking about a 4.4 basket trial, so realistically, 4, 5, 6 baskets, 3 baskets maybe in some cases. But I'm going to have 93.7% of those baskets that I carry forward are going to be effective ones. And so this number, the 93.7, this is really important to you, because when I go into phase 3, what my treatment effect, if I'm doing a pooled phase 3, I don't want to dilute my treatment effect much. So if I've got this 93.7, now, of course, in phase 3, I've got a mixture of groups that were 35%, and potentially, I hope I screened them all out, but potentially some groups that were at 10. And so when I perform a pooled analysis in phase 3, I'm going to get a weighted average of those. And so you can see basically this is saying that 93.7, the dilution is going to be small. I'm basically going to end up where my pooled treatment effect is probably going to be over 30. I'm not diluting it very much with the occasional 10% that sneaks into phase 3. And again, keep in mind, it's very hard to guarantee that I will never get a bad group into phase 3. It's just hard. And sorry, the reason I'm reemphasizing this is there's a lot of discussion over why can't you just do everything right? And it's sort of like, well, give me 10,000 patients and I can do great. Okay, so basically, this is true, this 235 as well. It also does a pretty good job of screening out the nulls and bringing forward the alternatives. Just because of the prevalence here, there's more nulls and less alternatives. You will see more dilution here. So this is more 78.8. But remember, in this scenario, the 235, I walked in with 20% of the groups effective. I'm walking out with almost 80% of the groups effective. So I am enriching. And so 8, you can see what I get here. If they're all 35, you can see what I'm going to do is I'm going to make some type 2 errors. My power isn't 100%, it's only 82.7. So I'm going to carry an average of about 8.3 baskets forward. Of course, they will all be effective because every group is effective. Whatever you pick something effective. Obviously, you don't know in advance you're in that scenario. So anyway, so I'm hoping that's clear on separate analyses. It does kind of the pros and cons here. It does a good job of screening things out when there's a mix. It does have a flaw that you've got this multiplicity in the null, and you're likely to carry forward at least one of the groups and have this kind of awkward basket of, I have to stand up a phase 3 trial in one basket that's hard to enroll, and it's a null. I can probably handle that with futility rules. I don't have to run the entire phase 3 sample size, but it's not going to be a good phase 3. It's not something a sponsor wants to get into. And so this is kind of the weakness of this separate analysis. So then on the bottom, we've got the pooled analysis, which is kind of the other extreme. And you could argue this is what standard drug development does, is a lot of times we enroll a population in phase 2. We may recognize it might be heterogeneous, but we basically ignore the issue. And if that phase 2 works, we go to phase 3, we pool everybody again. And so, what can happen is we can end up in a situation where, we don't handle the heterogeneity in the population. So to get at the pooled analysis, what this is going to do is we're still doing 15 per group. It's the same data, but we're analyzing it differently. And we're going to pool this over 150 patients. So I need 22 out of 150 to claim efficacy. And keep in mind, this is an all or nothing. It's pooled. So everybody is ineffective or everybody is effective are my only two conclusions. So in the null, this actually controls my type 1 error. I get my 4.4% on here. It's not quite equal to the separate because of the discreteness. You can't run, the multiple discrete things. You can't exactly equate type 1 error. If it were a continuous setting, I could make these completely apples to apples on type 1 error, but not possible here. So this is, again, this 0.44 out of 10. But keep in mind, this is a better situation because I don't have the multiplicities. There is a 4.4% chance that I have to start my phase 3 trial, and my phase 3 trial would be in all the baskets. So that would be awkward, but it's probably quicker. And again, I'll use futility rules to at least quickly recognize, because I have a good patient stream, that this doesn't work and I can move on to other things. In the all 35, if you do the pooled analysis, you basically get 100% power. It's many 0.999999999s. So this is the pooled analysis is basic. It's perfect in this all 35 scenario. You always make the right decision. Where the pooled falls down is in the screening settings, where what's going to happen is I have to either take all forward or none forward. And so I've got no way to enrich. So if I'm in this, let's talk about the half 35 scenario. It turns out, because I'm pooling and I have a fairly big sample size, when I've pooled everything together, I actually almost always win the half 35 scenario. My treatment effect is diluted, but I've got, I'm bringing 150 patients to bear rather than the 15 the separate analysis does. So I almost always win this, and I go to phase 3, but I haven't done any kind of enrichment. I'm still carrying 50% of my groups are effective. While I may win my phase 3, I have the obvious ethical problem that I am going to end up potentially approving a drug for a lot of patients where it doesn't work. If I think about this from a sponsor kind of perspective, what am I going to report as the treatment effect? Well, for some patients, they get a 35, for some they get a 10. And so I'm going to report this as, 22.5%. It's going to end up, my pooled point estimate is going to be in the middle, and it's going to apply to no one. So lots of issues if you're in these mixed scenarios. Okay, so those are the extremes. So what I really want to know, I've said most of this as I went through, is can we do better? Can we make a better trial here? And so what I'm going to do is I'm going to do periodic interims. So the standard thing in all adaptive trials. Usually these are based on overall sample size or time, every 3 months, something like that. You'll see some papers in the literature where they talk about doing interim analyses, like we're going to do interim analyses when every group enrolls 5 patients. That is usually it's easy to kind of write out the theory in that case. So this is a trial we were aiming for 15 per group. I'll do the first interim when all the groups are at 5. That's easy to write down and write out the theory. That is an impossible thing to make happen in practice. You will not enroll these groups in lockstep. So you will not be in this situation where they all hit 5 at the same time. And so what you either have to do, both of these you never want to do operationally, you either will have to pause groups. So, each group will hit 5 and I'll wait for all of them to hit 5 to do the interim. And then you'll have a couple slow enrolling groups and you'll be like waiting for this to happen. That's a mess. The other alternative is that you have to dynamically, whenever any group gets 5, you go, oh, I'll analyze that group now. Well, that of course means you have to do a gazillion interims because they're all hitting the triggers at different time points. So that just does not work in reality. So what you need to do is either do, I'm enrolling 150 patients total. When I get 50 in, I'll do an interim, and however they've enrolled to that point, that's what I'm going to act on. You can certainly say, I won't make decisions on groups that have very low enrollment. That's fine. But your interim schedule, you need to do something that you or your CRO or whatever can actually implement. At these interims, will allow groups to stop for futility or success. And usually what we'll do is some kind of modeling. So as I said, Bayesians often employ hierarchical models in this setting, whereas frequentists will often pool groups that are still enrolling at the trial's end, in the hope, of course, that they've got this enriched population, and that makes more sense at the end than what they would do at the beginning when you've got this mixture potentially coming into the trial. Both of these mechanisms, I'm not, my Bayesian frequentist, I'm not particularly, I'm not recommending one way or the other in this. They both tend to do reasonable things on this. So much like my statement about arm dropping or RAR, they're both good methods and do reasonable things, and you can argue about the details. My goal is to make the world better, not necessarily perfect. And in fact, I don't know what perfect is. So, okay. So let's see. So this is the design that I'm going to show you. So interims at 50 and 100 patients, final analysis is still at 150. At each of the analyses, I'm going to stop a group at the interim if the probability that group's rate, if the probability it beats 10%, if that's less than 0.6, I'm going to stop the group for futility. If the probability that I'm beating 10% is greater than 0.95, I'm going to stop the group for success. So this is going to eliminate a number of groups early. It will save sample size. It'll narrow the population. It will potentially allow groups that are still enrolling to enroll a few more patients because it will free up some slots. Again, you want to keep in track of the operational cost of that. And you may want to put some caps on the groups in here. So there are some operational tricks that you can do to make sure that your trial doesn't have a unusually large duration in this setting. But you should keep in mind that that is an implication. A final analysis, I'm going to have it 150, and I'm going to declare the group successful if the probability I beat 10% is greater than 0.95. So this is the same criteria here. I played around a bit with trying to make this criteria stronger, 0.99 and 0.95, and it ended up not making much difference. So I went ahead and saved the sample size in this case. I played around. I spent a lot of time on these three numbers, the 0.6, the 0.95, and the 0.95. I tried a lot of different combinations. And in many cases, they didn't matter. In a few cases, they did. I'll talk about that in a minute. Okay. All of my analyses are going to be performed with a hierarchical model. So the hierarchical model is a standard one you'll see in Bayesian inference. So each of the 10 rates with the logit transformation on them is assumed to arise from a normal distribution, and I've got priors on the mean and variance. So this is going to allow dynamic borrowing between the groups. If the groups all seem similar, and that might be they all are similarly effective, or they're all similarly ineffective, then the model will tend to borrow heavily between the groups. So you can expect a fair amount of advantages in those settings. In the joint null and the joint alternative, this model is going to be really helpful about getting closer to the pooled kind of analysis. Whereas if the groups seem to be quite different, some are at 35, some are at 10, they're far apart, you're going to borrow less information. It's going to look a bit more like separate trials, won't look exactly like separate trials. But anyway, the hierarchical model is trying to bridge the gap between the pooled and the separate.
Kurt, a couple of questions.
Yeah.
The first is, if the subgroups have different prognosis, might you have different criteria for different subgroups?
Yes, you will certainly. And there's a number of ways they can differ. This, I assumed my null was that they all had to beat 10%. You certainly could have different baseline rates for each of the groups. So for example, some cancers may have sadly abysmal response rates, whereas you may be beating 40, 50, 60% is you're trying to get 60 to 90 in groups that have higher response rates. So they may differ there. You may also decide that you want different criteria here, and that could be because of the utility involved. It could also be a simple matter of you need to run a feasible phase 3 trial. And so certain groups, I expect them to enroll more patients. I need them in the phase 3, or the phase 3 isn't even worth running. We've designed trials like this where we say we won't run the phase 3 trial unless one of these two groups wins the trial. Because otherwise we know we're going to run to phase 3, but we just can't enroll a phase 3 trial unless one of these two groups is in it. So certainly you can change these numbers around, but again, this is a balance. You want to have good inferential performance. You want to make the right decisions for the patients, but you also have to realize this is all entangled with operations because you're affecting your accrual, and things have to be feasible. And Tom, you said there was more than one question.
Yep. Well, remember, yes, there's the second question. What are the pros and cons of using predicted probability of success or posterior probability cutoff at the interim?
So there are, you can, trying to figure out how to get this in brief. It's a fascinating topic that I could talk about for a long time. Generally speaking, you can do either one. Predictive probabilities probably more directly answer the question. If you're talking about going into phase 3 in a phase 2 trial, I'd often want to predict what is the probability my phase 3 trial will be successful. A lot of times these will also they can be good approximations if you calibrate these numbers correctly. So if you say I want a specific predictive probability, you could pick these thresholds at each interim to probably emulate that. One of the reasons that we often use posterior probabilities is they're much quicker for the computation. So we often will do this, but I'm certainly a fan of the of predictive probabilities, but often this is easier to run, and it may be easier to implement. If you're going to pass this design off to a CRO, these probabilities there's often a lot of standard code for this. There may be less standard code for predictive probabilities. So certainly you can do either. Predictive probabilities are probably better, but this can emulate predictive probabilities pretty well if you're clever about it.
Thank you, Kurt.
All right, let me show you facts. So this is my facts file here. And again, we'll have a template. You can see this is template 3 because I kept playing around and comparing results. Let me go back to the beginning here. So this is, it's a single arm trial. So we're comparing to what's an objective control. We're comparing to 10%, a number. Responses are good. I want to prove I'm better, want to show superiority. I'm going to be adaptive. And I've got 10 groups with a maximum of 150. If you want to cap individual groups, you can do this here. So all of the discussion I had about ways to operationalize these trials, FACS is going to be flexible about allowing you to have caps on the trials, caps on the groups, and try to manage your enrollment to make the trial have a decent duration. I think I'm not using that particular one. I'm assuming a quick endpoint here, but keep in mind, a lot of times, especially in oncology, the endpoint might be longer. So this is probably unrealistic in this setting, but for illustrative purposes. But you can set, if it's a 6-month endpoint, a 1-year endpoint, and so forth. You can do basket trials in time to event where PFS is the endpoint, and you'd make decisions off hazard rates rather than responses. Certainly all feasible and similar issues. I've got my 5 profiles all defined. So the half 35, half 10, those are all pre-populated. Because the endpoint is so quick, probably the accrual rate doesn't matter, but I'm assuming 5 patients per week into this trial, and you have to specify how those split across groups. So I've assumed equal enrollment here. Every patient is equally likely to be from any of the groups. Clearly in practice, you may expect some of the groups to be more likely than others, and you can do that. FACS will even let you start with certain groups and bring other groups in later if you want to be, if that makes it more realistic. Certainly it's doable. No dropouts, but you can certainly have them. In the design, so my control rates, again, single arm trials. So I've assumed the control rate is 0.1%. These could certainly differ across groups. My treatment model, this is my hierarchical model. And I've put in, this would be another webinar. I think we've given this webinar somewhere. I'll have to find a link to it. But this is a pretty standard hierarchical prior. We use this as a default in a number of dichotomous settings. In continuous settings, this wouldn't be my recommended default. But this seems to give good performance. I've set the prior parameters. It's a good first step in terms of dichotomous settings. Not doing anything frequentist here. Largely, again, I'm not saying frequentist is bad. I'm saying that it's not what I do naturally. So I have interims, 50 and 100 patients into the trial. You can certainly change this. As with all adaptive trials, more interims is better, but their marginal value decreases. So, adding the first couple, big benefit, adding the third and the fourth, some benefit, adding it 11th to 12th, probably not so beneficial to do, not worth the operational cost there. And then I've got my success and futility criteria where I can specify how I'm going to drop groups. And so I'm going to do this. This is my futility. If the probability they're less than 0.6, then I drop the group for futility. You can put in different thresholds for every group. And again, you can do lots of bells and whistles here. If a certain group is necessary, you could say, look, if I can't get group 6 into phase 3, I'm going to stop the whole study. So that's it. Group 6 didn't work. I can't run a feasible phase 3. I'm done. That's a possibility there. And you can also put minimums. So, don't stop it unless there's a certain number of patients in the group. Similarly, for success, if I can get my probabilities over 95%, then I'll stop for success. These will also apply at interim 2. I could add another tab in and put different criteria in at interim 2. They'd have the same form. To get to your question, somebody asked a minute ago, I should have said this. You can do predictive probabilities of phase 3 success. And there's a number of ways. FACS will also run a pooled analysis. It's actually a stratified analysis, but it assumes a common treatment effect. And you can do all kinds of ands and ors and combine rules together. So it's lengthy, the possibilities that you have here. What I've described is probably the most common setting, but FACS has a number of ways to tailor things to exactly what you need for your largely operational needs, is where you would use these features. At the final analysis, I've got the group is successful if my posterior probability is above 0.95. And again, I could base that on the probability of phase 3 success. And so these are all entered in again. When I was trying to optimize this design, the only thing I did is I went back and forth. I would change these numbers, the probability of success at the final, and I would change these numbers, what I need for futility, what I need for success for each group early. So these 3 numbers, I just tried different things. So over and over and over again. Tom, it would be nice someday if we had as I did this a bunch, if we had a little box that would just say use the same threshold for all groups. But anyway, it's not my highest priority. But as I did it a bunch with a lot of groups, it would be valuable to add to our list of UI improvements. But anyway, easy enough just to go through. Certainly, a lot of these trials have 5 or 6 groups, and this is easy. If you've got 30 groups, I think you'll find it a little tedious. So certainly not trying to. We'll continue to try to make things better. Okay, so then I can simulate this trial, and I get my results. You can see facts is giving you the mean number of subjects, and it's giving you the probability that you are successful in each of the groups. Now, what's going to happen here is when I look at my probabilities of success, for example, this is the joint null. All of the groups are at 10%. I expect that it will treat all of the groups equally. My model's exchangeable. The groups have identical rates. So you can see the probability that my group 1 is successful is 0.0085. The probability that group 2 is successful is 0.0088. These are entirely simulation error. The true rates are identical, but you can go across and you can see various 0.00. There's a 0.0095, 0091. But anyway, these are all simulation difference. There's a 0.0073. But anyway, you can see there is some differences here, but they are all simulation based. You can also see, for example, in the half scenario, you can see the probability that an effective group graduates is about 0.77, 0.7725, 7735, 7685, 7688, 7675. And then the ineffective groups, they're at 0.1822. I'll talk about the pros and cons of that number not being tiny in a moment. But anyway, so this is, you can see the essentially the real operating characteristics that you care about is what are the odds an effective group gets carried forward? What are the odds an ineffective group gets carried forward? And so I've copied these numbers out, and let's go back to the results. So what I've tried to do here is add the adaptive results on top of what you've already seen. So this pooled table, this is exactly what you saw before. In the top table, the first set of numbers is what you saw for the separate analyses. And then I've put a slash, and I've got the what you see for the adaptive basket trial in here. So we can do some comparisons. I've also added an expected sample size because the basket trial, it is smaller. It is much smaller in the null, joint null and joint alternative. It is modestly, maybe this is more than modest, decent sample size savings here, but we'll call it modestly smaller in these cases for the average sample size. Okay, so one thing you have to keep in mind, this is where we get into trade-offs. No method is going to dominate where no matter what the scenario is, one of these designs is always the best. So you often have to think through this. What is happening in each scenario and which scenarios do I care most about? And then do a summary. So this is a hard, if you're a consultant, or if you're a statistician at a company trying to communicate this design, this is a challenging design to try to communicate well. And I certainly don't claim that I have any monopoly on doing this perfectly. Okay, so let's think about each scenario. So in the joint null, the adaptive design's actually doing really, really, really well. And the reason is, first off, the expected sample size. So I haven't quite saved half my patients, but I've saved 40% of them. So it's much smaller. The other thing that I've got here is if I look at the group-specific type 1 error, it is at 0.0085. Remember, this is a trial that has combining information strongly in that setting. And so I get this group specific on average, instead of taking 0.5 ineffective baskets forward, I only take 0.08. It is really good about screening out all of the ineffective groups in the joint null. That's not going to hold in general, but in the joint null, it rocks. It also has the advantage that the probability of going to phase 3 at all, remember, there are 10 groups here, but they're also correlated because of the model. So both the pooled and the adaptive trial, there's only about a 4 or 5% chance that it's going to say go to phase 3 at all. Whereas remember, there's a multiplicity. While the average number of baskets that you carry forward is low in the separate analyses, there's a good chance it's going to say, take that one. So you're going to get that random high, and you're going to have to go to, I really stand up that that single basket. And so, that's difficult for the separate analyses. And, if you're thinking, oh, well, maybe I'll never go if there's one basket, I'll only go if there's 2 or 3, that has knock-on effects. It's hard. Every change you make to make one scenario better, it often makes the other scenarios worse. So, keep that in mind. But basically what you're seeing, there's no question the adaptive design, if you were in the joint null, the adaptive design is your choice. Limited chance of going to phase 3 and smaller sample size, everything's in its favor. Okay. When you get to the other scenarios, so for 235, so there are 235s, there are 8 nulls. What you're going to find here, remember, the pooled analysis wasn't doing incredibly well. It actually carries forward, you go to phase 3 about 60% of the time. This is on average, you carry 5.8, but remember, you have to carry forward all of the baskets. So you end up carrying forward a lot of groups that don't work. This is a situation I really need to screen out these ineffective things, and the pool doesn't do it. The separate analysis, you can see it does screen out fairly well. So this, I'm only carrying forward about 0.4 ineffective baskets. The adaptive trial is still doing pretty well here. This is I should have given the second digit. So 0.44 versus 0.40. So these are pretty close. They both of them weed out most of the ineffective baskets. So remember, this is out of 8. And the difficulty is for the adaptive trial, it's a little bit worse about carrying forward those 2 effective ones. So instead of 1.6, I'm only carrying forward 1.1. This is a function of the borrowing. So there are lots of ineffective groups. The model has a tendency to go, those 2 that are effective, I don't know, you're surrounded by a lot of ineffective groups. Maybe you're just a random high. And so it tends to borrow and pull those down. So you can see, the effect of this in terms of the enrichment. The separate trials, they carry forward 78.8% of the groups that are carried forward are truly effective, about 73.6 for the adaptive. So I think the adaptive is modestly worse than separate here, but it's certainly both of those are beating pooled. Pooled is not doing well. And the sample size for adaptive is a little lower. You'd have to, between separate and adaptive, you'd have to weigh this sample size versus this modest inferential cost here. In the half scenario, it's actually fairly similar qualitatively. The pool does badly. The separate does a good job of screening things out. The adaptive trial, it starts to do a bit worse. It lets a few more ineffective baskets through. It gets about the same number of effective baskets, but a little less. And again, you can see, the enrichment fraction here is a little bit lower, and you don't really have much sample size savings. So I'd say here, I should have gone on to the next slide. Here, probably separate is the best. and adaptive's a little probably meaningfully worse. This is probably more of a toss-up for this, but that's my subjective opinion. Your mileage may vary.
Kurt,
Yes.
I got a question. In your slide, in your results in slide 10 and 13, we can see a lot of similarity in the findings to the case where we disregard the randomization scheme when analyzing the data in a two-arm standard trial. I'll try to understand the point there. For example, if we disregard the stratification factors in analysis, we might lose some efficiency or precision. It seems to be the same here in basket trials in the pooled analysis, particularly when the underlying effect is different in different subgroups.
I'm trying to process all of that. I think the answer is, I'm going to say mostly yes, and I'm worried I didn't get all of it. Certainly what you're seeing here is the fact the treatment effect, the reason the pooled is failing is the treatment effect is assumed to be equal in all groups. You certainly can fit stratification variables, but the key issue is the treatment effect is being considered equal. And so the model's just not capable of recognizing that some groups work and some groups don't. You're enforcing an all or nothing decision. I don't think that answers the question, but I'll be happy to take a follow-up for what I missed about that.
Okay, I'll see if,
apologies for the imperfect answer.
Yeah, I'll see if we get a follow-up. I'll pass it on if we do.
And certainly Tom or Nick, if you want to see that as well, feel free. All right, so let's see. For 8, I think the 835 is kind of a toss-up here. There are the adaptive average sample size, you are starting to see some savings. You actually get a bit more power in the adaptive than separate, about half a basket more. This may or may not be that meaningful to you depending on the setting. You carry more ineffective baskets forward, and you can see the enrichment fraction is lowered for the adaptive. But I don't know, with the lower sample size, the little extra power, maybe that's not that big a deal to you. It's not clear to me that this is necessarily bad. If you're 80%, I'm at least virtually guaranteeing I carry all 8 effective baskets forward. If my phase 3, if I'm going to do some subgroup analyses, it's quite possible the pooled analysis may be viable here depending on the setting. And I would argue that this is probably a lot of standard drug development. So, I enroll a broad population. Most drugs probably don't work for everybody. I would run a pooled analysis, run a pooled phase 3, and I'm going to find in practice this drug doesn't seem to benefit everybody, and I'll have second and third line therapies for people who don't respond. So this may simply be standard drug development as we have it now. So it's a little difficult to guess there. In the all 35, I think the adaptive trial probably is winning this one as well. The power of course, there are no nulls, so I don't have to worry about screening anything out. The power here, remember, I'm borrowing. So I have, compared to separate, I've got this 98% power. The pooled analysis is 100% power, but the adaptive trial does it for half the sample size. So I think, unless you really care about that 1.5% power, I think you take the half sample size here. Obviously, there may be cases where you want that extra power, but I think most sponsors would pick the adaptive trial clearly in this case. Okay, so that's one of the things that makes it hard, is it's like, well, okay, so in this scenario, that was better. In that scenario, that was better, blah, blah, blah. What do I pick? I got to do something. And so I've kind of summarized in this slide what was going on. And what you can really see is happening here is the pooled and separate analyses. They do well in certain settings, but do really badly in others. So it's a high risk, high reward in both of these. For the pooled, you do well in the all 10 and all 35. Not surprisingly, the pooled analysis does well when in fact the treatment effects are equal. But you have problems when there is heterogeneity. So the pooled analysis, it can't detect it, it does badly. The separate trials, they're almost the reverse. They're pretty good about screening things out, but your power's reduced in the joint alternative pretty significantly, 80 versus 100. And the other issue that you have is this notion that because I've got this type 2 multiplicity, I'm often going to be stuck on, oh, what do I do when this says 1 or 2 baskets work? Am I really going to run this hard to deal with phase 3? Or am I going to, if I start to say, well, no, I'm only going to run a phase 3 if 4 baskets win, well, then, if I need 4 baskets to win, suddenly it's not going to be doing well in this 235 because I'm now, anyway, if you fix this problem, you hurt these groups. So there's no free lunch. So you do have this high risk, high reward. What the adaptive is doing for you, and I'm not saying it's the best option. So please, I'm trying to I don't want to ever come across as there are lots of cases we say don't do an adaptive design, don't do borrowing, don't do historical borrowing, don't do RAR. There are lots of cases we say these things. Just, how would you weigh these trade-offs? In the adaptive design, I do think it is the clear winner for the all 35 and all 10. You get performance pretty similar to the pooled, and you get it for significantly reduced N. So I think that's great. The adaptive is the clear winner here. What you will see for these mixed scenarios, the 235 and the half 35, is that the adaptive trial, it screens a little bit worse than separate. So it brings in a few more ineffective groups. But it does perform closer to separate than it does to pooled. So while the pooled is doing really bad here, so what am I trying to say? If separate gets an A and pooled gets, a D here for a grade, this is getting you a B on this. Same kind of situation here. You're getting a B. And so what you're trying to figure out, if this is an F and this is an A and this is an A and this is an A and this is, a C minus, if this is, an A plus and this is a, B plus, B plus, this is, I'm going to give everything an A here because I'm really not sure what's best. And then, this is an A plus, how do I weigh, and, maybe I could have called these B minuses, maybe this is a B plus and a B minus, but, what is the combination here? And, how do you weigh that fact? If you came to me and you said, I'm pretty sure that this drug is effective for everybody or effective for no one, yeah, maybe it's possible there's some heterogeneity, but I don't think there is. I'd probably tell you, the pooled is where you want to be. It's not likely enough to buy the insurance policy, so to speak. I live in Kentucky. I don't have hurricane insurance. In contrast, if you told me that these were fairly likely, then I would be leaning towards the separate or adaptive trial. And I would take you through, you have to worry this bad performance in the null, the sample size gains in the adaptive, and do you want to screen a little bit worse? How do you weigh those things? And if,
So
if you're talking about if you could give me a utility function, here's my actual value. We have, products like quotes, which will do net present value. I can go through all of those and get the trade-off. So I'm not going to tell you what to do here. I'm just saying this is what you have to weigh and why you have to weigh it. And then you've got to make a reasonable choice on this. And in some cases, we might pick each of these depending on what the setting is.
So Kurt,
Yeah.
One question is, this is a very helpful summary. Thank you. Is there a publication we can use as a reference?
For if you're talking about these kind of trade-offs, no, but we actually are writing one. Now that said, I have no idea when it will be out. Maybe the right thing for me to do, it will not be a paper, but I can likely write up kind of a white paper. We'll submit a version for it to get through peer review, but that will get things out sooner to write this. And obviously, this is our opinions, not through peer review. So I haven't gotten 3 randomly chosen referees to agree with me.
And second question, I'm a bit surprised that 235 and half 35 has worse power to pick the winners. Since you're already using dynamic borrowing, shouldn't the effective subgroups with higher ORR borrow less information from ineffective groups, thus having less bad influence and still maintain a good chance to stand out?
So that is that can be a function of the details of the hierarchical model. I have the hierarchical model set to kind of do a middling level of borrowing, which we tend to like in practice. If you send me an email, I'll send you a slide deck on where this comes from. If you wanted to get better performance for the adaptive in this scenario in particular, I could change the hierarchical model parameters so it acts a little bit closer to separate. Right now, what it does is it borrows a bit, probably too much in this scenario. And so it brings the effective groups down, it brings the ineffective groups up. Not catastrophically, I don't want to say that, but does it more than separate, and you could do better in this scenario. Now, the reason, of course, I didn't do that is those settings that I have are part of the reason I get the great performance on the edges here. So making it work better for half 35 would require bigger sample sizes and worse performance in the joint null and joint alternative. So everything, and I certainly would recommend you try different settings. So if for that, I would play around with the hierarchical model settings.
Thank you, Kurt.
And then I know this is scheduled till 12:30. I'm going to talk a couple minutes extra. This is all recorded, so hopefully you can either stick around or watch it at your discretion. But one discussion on regulatory. The regulatory pathway right now for basket trials remains unclear. There are differences between divisions. This is best established in oncology. There are a number of other settings where we have been proposing and having discussions, I think good discussions, but you will see differences here. One of the key issues is what is type 1 error control? And you'll have a discussion on sorry, I should premise this in a phase 2 setting, you're fine. No one's gonna, there's no worries in phase 2. In phase 3, the key issue is type 1 error control. And so for some settings, what you're asked to do is control type 1 error in the joint null. So, can I control that? Can I do that? The other thing that they could ask is, are you required to have family-wise type 1 error, where in effect, approving the drug in any ineffective subgroup is a type 1 error, and I want to avoid that. That's a very stringent requirement, and it's actually so stringent, it almost defeats the purpose of asking the question in the first place. Keep in mind, I've heard a lot of FDA people say reasonably, we probably make type 1 errors. We make family-wise type 1 errors all the time. So if anytime a drug is approved where there's a subset of patients where it doesn't work, you have committed what would be a family-wise type 1 error. There's a group of patients who did not benefit from the drug. So if if a drug works in, I've got 10 groups, it works in 5 of them and doesn't work in the other 5 groups. If my conclusion is give the drug to the 5 where it works and give the drug to one of them where it doesn't, I've committed a type 1 error under the family-wise definition. So that is, that's hard to avoid. You would also potentially argue there's a degree of mistake. So, is a type 1 error like I just described, I got the 5 where it was effective correct, and I only made, I correctly screened out 4 where it didn't, but I didn't screen out 1. Is that the same level of mistake as giving a null drug to everybody? A drug that does nothing, I give it to everybody. Are those the same mistake? Should they be calculated? Is this the same error when you're calculating the probability of a type 1 error? Is one of the counter arguments to family-wise type 1 error. The other reason that family-wise type 1 error is so hard is it's virtually impossible to borrow information in any way. So the only thing that you can do is do separate analyses. It forces you to do separate analyses. And it often forces you to do separate analyses and split your alpha. And so sponsors are often in a really difficult setting, whereas if they're thinking, maybe I have heterogeneity of treatment effect, if you're in a setting where family-wise type 1 error is going to be the requirement, it's very difficult for you to go to a regulator and say, I want to consider this, because now I have to power all of the subgroups. I have to take an alpha penalty. In many cases, it might be easier for the sponsor, and I'm not saying I like this scientifically, but it might be easier for the sponsor to go in and say, I'm not going to talk about heterogeneity of treatment effect. I'm going to run a pooled analysis, and I'm going to do post hoc subgroup analyses at the end, which, that gets done. Occasionally, a label is not the entire population. That process is not family-wise type 1 error controlled, but it is far easier on the sponsor. And so you run into situations where I'm not sure a sponsor, if the requirement is family-wise type 1 error control, I'm not sure that's a question it's difficult to breach the question and actually address without suddenly having your sample size be 6, 8, 10 times higher than it otherwise would be. So I think this is one of the difficulties, and I'm hoping, complete personal hope, that we will eventually be dealing with what is a type 1 error and the magnitude of mistake. So, basically issues like, well, what percentage of the population are we bringing forward incorrectly? And, maybe we want to make sure to have something equivalent to a 5% in the joint null, recognizing, these are separate decisions. But anyway, I think that's a research area, and the regulatory path is unclear. But this is one of the reasons you don't see a lot of baskets in phase 3, is the difficulty in figuring out exactly what needs to be controlled. All right, so summary here, basket trials, you're interested in heterogeneity of treatment effect. You do have a way to screen out ineffective baskets. You do get effective enrichment. There are ways to do this efficiently. There are trade-offs. You need to think long and hard about the scenario and pick the design that's best for the scenarios you think are most likely. And also, as a final note, always keep track of the operational issues. because getting rid of subgroups, you are getting rid of accrual, and that is problematic for duration of trials and feasibility of trials. So let me end there, Tom.
Yeah, so no new questions. Just a thank you.
All right, what's next week?
Right, next week will be MAMS trials, multi-arm, multi-stage, and platform trials, and we'll kind of compare and contrast.
All right, I will see everybody later.
Thank you, Kurt.